It's the health belief model. And while there's some debate as to whether it's an effective way to try to do research, I think it's a really effective model for us to talk about, to think about how does cultural competence relate to these various pieces of the health promotion model. This was put forth by Rosenstock, Stretcher, and Becker in '94 and has been augmented since, and we'll be talking about some of those augmentations. So I want to talk about the elements of this health belief model, just go through them quickly, then we'll go back and revisit each one and talk about it in terms of the cultural competence issues. But it's a good way to even help you think about where you're going to need to intervene if you're going to want to change health beliefs and health behaviors. The first one is that there has to be a perceived threat. So for example, somebody has to think, this bad thing that you're talking about could happen to me. And that's in two ways. One is that that they're susceptible to it. We call it perceived susceptibility, that it's not just something that happens to other people, but it addresses me. And the second is its perceived severity. It may be the sort of thing where you think like, well, yeah, it could happen to me, but how bad is that? I think an example of that in the US has been the issue of people being overweight. For a long time, everybody thought like, yeah, I know, if I eat too much and I'll be overweight, yeah, that's, it affects me. But how big a deal is it? Well, now we have all this information coming out, is that we're calling it one of the leading causes of death in this country. So it begins to shift the conversation. Now you see a lot more interest in people thinking about how are we going to address this issue because of the perceived severity. Perceived benefits is another piece of it, another element of the model. Somebody might think that, yes, it's a problem for them, but the thing you're suggesting that they do differently, so for example, putting babies to sleep on their back on a firm surface, doesn't make sense to them. They don't see that that's going to really have an impact on the problem that we're talking about. So you have to think about the perceived benefits. There's perceived barriers. They may even agree that whatever you've suggested is great, but for some reason, they're not going to be able to carry that through. Then there's what the model calls cues for action, and that's all of us. It might be somebody going to a training. It might be seeing a poster on a bus. It might be a public service announcement, a pamphlet. It's something that happens in the environment that cues the person that they need to focus on this and change their behavior. And then the last one is self-efficacy. Do I actually think I could do what they want me to do? And this is one, as I use the weight loss example, a lot of people say, I know it's a problem, but there's nothing I can do. I can't change my behavior. So when we're thinking about health promotion, we have to think, where among those different elements do we really have to apply the pressure? Do we have to think about intervening? So I want to go back now and examine each of these elements in terms of how we can use them to help us think about cultural competence in our health promotion. So let's start with perceived susceptibility. That's really, am I going to get this disease or this negative outcome? Will it happen to me or my family? As we're thinking about health promotion in culturally diverse communities for individuals and families, we need to think about things like the community's level of knowledge about the problem. What we often find out is, though, while we're reading all the literature about health disparities and problems, that actually the communities affected often aren't even aware that it's an impact for their community. So we really have to assess, is that something people are even aware about?
I lost a little boy, 9 months old, Armani, to sudden infant death syndrome. It was very devastating. After carrying this child for 9 months and you're looking forward to your first son, well, we knew it was going to be a boy, so we were very excited about that, and he was our first. And while I was pregnant, I had read the book, What to Do about during pregnancy, What to Do the First Year. I think everybody's seen that one. And I saw a very small little chapter about sudden infant death syndrome, and they also called it crib death. But as an excited mom, I figured, who needs to read that? That'll never happen to me. I don't want to know anything about a baby dying. Like my mom, aunts that are older, and grandparents and all, they don't seem to be so in tune to this SIDS, sudden infant death thing. They don't believe that it exists, and my mom just does not still believe that a child can just go to sleep and not wake up and there's nothing wrong with him.
So much of the information that goes out about health promotion issues is in written form. I mean, whether it's in the newspaper or an article in a magazine or a pamphlet that's given out at the doctor's. If we're dealing with families or individuals where they have low literacy or can't read, then they may not even know that it's a problem for them. English proficiency is another issue. If we only provide information in English and we have individuals who don't speak English, again, we're not going to have them understanding that this is a problem for them or their community. And then, as Tawara talked about, there's culturally based health beliefs and values that impact how people take this information in. So that if they have a particular culturally based perspective on what causes disease, and we're providing information maybe from our scientific perspective, they're still not going to see that it's a threat to them because it just doesn't make sense.
The one typical thing is that the doctors here always suggest babies can never be overdressed. They need to be kept cool. But the Chinese parents always think the babies are afraid of cold and you need to dress them twice than the adult will. And that's always a problem we discuss and we argue with our parents.
So then we have the issue of perceived severity. You know, in other words, is there going to be a serious problem for me or my family, even if this thing happens to me or I get this disease? And again, we have to think about, not just from our own perspective, you know, we might think that, oh, if this happened, that would be terrible. But we meet families and individuals who come from all sorts of experiences and backgrounds. So, for example, previous experiences with trauma. We have many refugees in this country who've experienced intensive trauma. Many of them have post-traumatic stress disorder. Having something negative happen to them will have a very different impact. It may either be intensified by their experiences, or compared to our reaction, it may not be as intense because they've seen so many difficult things in their lives. And then lastly, for some folks, they have a sense of acceptance based on their religious or spiritual beliefs. You know, that it's God's will. And so taking action to try and change something that's God's will, again, may not be something that will motivate them to do the kind of belief and behavior changes that we want to do related to health promotion. So now let's talk about the perceived benefits. You know, will it work? Again, we want to think about health beliefs. You know, if you have a belief system about what impacts your health, and it's not based on our scientific model, then we have to understand that and know that somebody might say, well, that's an interesting thing to do, but it doesn't make sense in my health belief system. My health belief system says that what will keep my baby healthy is keeping hot and cold in balance in their system. And you're talking about putting a baby to sleep on their back. How does that connect? So we have to understand that to know how do we connect that together.